Welcome to the Quality Improvement Basics course, Data Basics and Data Collection module. Our topics for this module will include using data basics, differentiate between qualitative versus quantitative data, select or create appropriate measures, and data collection methods. Please note that there are several references to the Plan, Do, Study, Act PDSA Rapid Cycle Testing tool which precedes this module, and the assumption is that you have a basic understanding of that. Also, before we start, please open the related documents for this module, tools, templates, and any samples, which are available on the web page where you found this module link. It will help you to have those ready for quick reference, as screenshots of the documents may not be legible on your screen. Using data basics. One of the giants in the field of quality improvement, William Edwards Deming, is attributed to this brief but poignant quote, "In God we trust, all others bring data." Data and verifiable measurement is key to identifying and understanding the processes we seek to improve. To be useful, measurements need to be valid, that is, they need to measure what they are intending to, and reliable. If the same thing was measured multiple times or by different people, you would want it to result in the same value. In other words, your data must be reliable and credible. Additionally, you are using data not only to confirm that you are making improvements in understanding the process you are analyzing, but also you'll use data to convince and persuade others to understand change that is needed and agree to your recommended changes. And that is why using charts, graphs, and tables in an effective manner will be an important part of your quality improvement work. Most healthcare organizations already have considerable amounts of data from various sources, such as clinical records, practice management systems, satisfaction surveys, external evaluations of the population's health, and others. Using this data in a disciplined and methodical way allows an organization to evaluate its current processes and systems, identify opportunities for improvement, and monitor performance improvement over time. Data is indeed the cornerstone of quality improvement and enables organizations to describe how well current processes and systems are working. Data also demonstrates what happens when changes or modifications are made and enables us to then identify variations that may be occurring in our processes. By collecting and analyzing data over time, we gain further insights into our processes, and ultimately, after we have made changes and accomplished the goals of our quality improvement efforts, this data demonstrates and documents the success we have achieved. Data sheds light and clarifies what otherwise are hunches or guesswork. It separates what is thought to be happening from what is really happening. Data helps us set a baseline from which to measure the changes we are applying to our processes and is the indicator for whether our changes have led to improvements. Sometimes in our efforts to make improvements, the outcomes lead to negative impact or unanticipated results, and the data will provide transparency into these ineffective solutions we have attempted. Conversely, when we are successful in modifying and improving our processes, it's not sufficient to have a one-time success. Rather, we want to ensure improvements are being sustained over time, and our process measures and underlying data help us to monitor that progress. When we use the Model for Improvement and Plan, Do, Study, Act tool, we start small and then spread or scale the improvement. Through data collection, analysis, and comparison, we can then also determine whether our process improvement is effective beyond our initial test location. When you are starting out on your quality improvement efforts, be sure to keep things simple and within the defined areas of improvement, which you documented in your project charter, the scope of your project. It's easy to want to accomplish change on a broader scale, but starting on a limited scale, one department, one location, whatever may be appropriate, will help you determine and be confident that the changes you have made are reflected in the variations in the data you are collecting that supports the measure you have chosen. If your scope is too large, you can't be certain that the variations in the data that you are seeing are directly correlated to the specific changes you have made in your process. As you carry out each PDSA improvement cycle, the changes will impact the set of data you are collecting and, therefore, impact the measure you have selected. Be sure to communicate or tell your story using the data you have collected. Having a set of confirmed facts and findings as a basis for your chosen measure is a powerful way to paint the picture and convince yourself, your team, and all process stakeholders of needed action. You've likely heard the saying, "You're entitled to your own opinion, but not your own set of facts," which speaks to the core of using data for quality improvement. Quantitative versus qualitative data. Both quantitative and qualitative methods of data collection are helpful in QI efforts. Quantitative data involves the use of numbers expressed in measurable units and is often continuous, such as height or length measurement. Quantitative data is objective and produced through processes that are verifiable, replicable, and not subject to interpretation. Quantitative data can be very helpful in looking for patterns and themes and can be processed utilizing software such as Microsoft Excel, population health analytics packages, and many others. If you've ever recorded a blood pressure, height and weight, looked at a hemoglobin A1C value, or other similar lab values, you've looked at and worked with quantitative data. Here are a few examples of using quantitative data in healthcare: finding the average of a laboratory value, recording patient vital signs or plotting the values on a graph over some period of time, calculating the percentages of patients that receive an appropriate health screening. Qualitative data is data with descriptive characteristics rather than numeric values. It can also be categorical or placing observations in specific categories. Qualitative data conveys attributes and properties. It provides important information about patterns, relationships between systems, and is often used to provide context for needed improvements. Qualitative data would include data that is collected in patient and staff satisfaction surveys, focus group discussions, independent observations. Race, ethnicity, language, or REL data are a set of qualitative data that are used to better understand patient populations and identify health inequities. Qualitative data could also be observations that are narrative in nature, such as an encounter note in a chart. Think of the root word of qualitative: quality. Qualitative data is the collection of data which are the qualities about who or what is being observed or described. Here are some examples of quantitative and qualitative data. A shorthand method to remember the difference is quantitative data is generally a quantity with qualitative data describing qualities about what you are collecting. In the columns on the slide here, we have a short list of examples for each category. Quantitative would include temperature, height, weight, waiting time, blood glucose level, and blood pressure, with qualitative examples being notes from meetings, discussions, narratives such as encounter notes, again race, ethnicity, and language, and blood type. It is important to determine which type of data you are collecting, as it will impact how you're able to conduct analysis on it and which data visualization tools you'll be able to use to tell your data story. We'll learn more about presenting the data using charts, graphs, and tables in the next module on data. Selecting measures. When deciding what to measure, there are two main types of measures: process measures and outcome measures. Process measures will tell how well our process is working. Examples may include the number of people assessed for a fall risk, or the number of people screened for a referral. Process measures are typically employed when it is thought that there are specific actions that either represent high quality or are likely to promote high quality, such as following guidelines or best practices. They may also be used when trying to promote standardization. Are all providers remembering to ask their clients with diabetes when they last had an eye or foot exam, for example? Process measures assess our processes. Are they still working for us? Are we using the process we have in place? Are we using them accurately and adhering to policies and procedures that support them? If a process or procedure is changed as part of a corrective action, it is important to know if the change actually occurred. If the outcome improves, you want to know if it was linked to an actual change in the process. This is why we make one or a few changes when we test changes using the Plan, Do, Study, Act PDSA tool. Here are some additional process measure examples. The number of patients that receive a second blood pressure check if the first measurement is elevated during an encounter. The number of patients over 18 who are screened for prediabetes that are not already diagnosed with diabetes or gestational diabetes. An outcome measure, on the other hand, reflects the result of processes currently in place, our services and interventions, and in healthcare how the patient's or population of patients' health has been impacted either positively or negatively. Outcomes in healthcare are the result of many processes working together. They are the result based on a particular system we have designed to produce those results. Recall the QI foundational module and the discussion about processes and systems and how systems are based on multiple processes. If you want to establish that a change to the process and ultimately the system had the desired effect on the overall health of your patients, some type of outcome measure will be needed. It's not enough to simply measure the process. What is the outcome measure telling us? What was the impact on the patient population? Did the change in our process or processes have the desired result? When you want to see a change in outcome, Eliminate the underlying recurrence of the event, which is the result of processes and systems that produce these undesired outcomes. Some outcome measure examples include the number of patients diagnosed with hypertension that have their blood pressure under control, readmission rates to hospitals, and facility-acquired infection rates. As your team determines what they need to learn about a particular process or outcome, you'll be one step closer to defining the measure needed to compare what the current state is and whether changes you make have led to improvement, the future state. What problem have you identified and desired to measure and analyze? Will the chosen measure yield the knowledge needed at the level of detail needed about the process or outcome? How will the measure influence your audience? As we learned in the change management module, your audience will need information and sometimes convincing and motivation to change and make the transition to the future state. Does your measure and the underlying data help accomplish this? Are you able to collect the desired data? This is a segue to the next section in this module. You'll need to determine whether the data you desire can indeed be collected. You may find that you can jump ahead a few steps in the process if you determine that the measure you have chosen is one that is already being collected and reported. It's also not uncommon for QI teams to be focused on existing measures that are reported to state or federal programs. Your organization may be rated directly on specific measures, and the fact that you're not performing well was the catalyst for creating a QI team and prioritizing improvement projects on these measures. Another quality improvement tool that you can utilize is the Measure Collection and Monitoring Plan. For each measure that you choose to collect and monitor, there are 6 questions you can answer that correspond to the columns in this tool. Use one row to document each measure. The questions are, what are we measuring? Describe what is being measured. Also enter any standard name if there's a state or federal quality measure naming convention for the measure you are tracking. When are we measuring, or frequency? Indicate the frequency with which you are tracking the measure and/or pulling data. Who is responsible for tracking this measure? Include a specific name or team member here. What is the current performance goal or aim? If this is a standard measure that you've been using and have a baseline value, enter that here. What is our performance goal? Enter your targeted performance goal for each measure here. How will data results be tracked and displayed? Include any notes, descriptions, comments as to how you'll track and/or share and display the measure, such as in a report. Data collection methods. There are several steps included in a data collection strategy. Determining what information to collect and how to collect it will frequently be considered together. For example, if you want to collect customer satisfaction information, your method of how to collect will obviously need to involve some sort of interaction with the customers themselves, a survey, interview, etc. The frequency with which you collect data, how much you collect during each collection period, and for how many periods will all determine how much data you end up with. It can be difficult to know how much data you will need to collect. If possible, look at previous quality improvement projects within your organization or turn to external sources, perhaps from published literature or online sources, to see how they have conducted measurement and what data they have needed. You can also conduct a few trial runs for a couple of time periods to see what kind of data you are getting and if there are any barriers or circumstances that you had not thought of. You will need to balance the need for enough data to identify a change in your process with the reality that there are always limited resources for collecting data in terms of staff, time, and effort. Another item to consider when determining a data collection strategy is how you will assess the results. That is, consider what would you like the endgame or final report to look like before you even begin. Once you have identified a strategy, you will need to determine how exactly you will track, display, and assess the results. The answers will also help you identify which type of charts and graphs will be best suited to your situation. You may find that there are multiple ways of collecting the data you need to support your chosen measure. Generally speaking, you do not want to make it too complicated. Simpler is better. Here's a list of methods to collect your data, measure performance, and track improvement. Keep in mind that many will have trade-offs between the time they require and the level of detail they provide. Tally sheets and checklists may be a quick method of gathering data depending on the level or amount of detail in the data you are collecting and the length of the time period being observed. An example of this is counting the number of instances when something occurs in a process, such as the number of screening questionnaires that are provided to patients versus how many are actually filled out. Questionnaires and interviews, on the other hand, may involve a significant time investment to collect and analyze, but they may provide a much deeper understanding of your process. This type of data collection is qualitative in nature, as the data, for example, may describe patient observations and feedback about the care they received during a hospitalization or a clinic encounter. There are several other methods, such as observations, daily reviews, and chart audits. However, one of the most efficient methods for data collection is to determine what data you may have already entered and stored in your electronic healthcare record. Check with your EHR expert or super user, if that's not your role, and also determine if there are any native or third-party reporting or data extraction tools that are part of or integrated into your EHR. You may also be measuring and analyzing a process for which you are already producing quality measures for a state or federal reporting program, so there wouldn't be a requirement to recollect or compile this existing data. Depending on the situation, sampling may be an effective strategy to speed up learning and improvement. Sampling is collecting a portion rather than all of the data with the expectation that it accurately represents the larger complete data set. For example, if a public health official wanted to understand if an initiative to increase influenza vaccinations was effective, they would probably not need to collect data on every single person in the community to see if there was an impact. Instead, they could take a sample of clinics and only during a portion of the flu season to assess whether a change had occurred. Consider your individual situation to determine whether it is necessary to collect data on everyone or whether a sample, a subset of the population and instances, would be sufficient. As there are often many considerations to deciding how and whether to collect sample data, it is a good idea to consult a data analyst or statistician who can provide guidance on this. Determining the frequency and duration of data collection will also impact your chosen sample size. The frequency will need to be often enough so that you are confident that the data represents the process over a sufficient amount of time and, for example, doesn't represent a period of time where there were unusual outliers in the data, such as only peak times, weekends, etc. With regard to duration, the time frame is often longer than you would like it to be. You first want to have a data collection period long enough to represent what is happening in the current state process and the collected data isn't impacted by the unusual outliers just mentioned. Once you make your improvements and modify a process, you'll then want to collect an appropriate amount of data to confirm the change occurred, but also whether the change is sustained going forward. For process measures, you want to be certain that the process is being consistently carried out over time. For process measures, you want to be certain that the process is being consistently carried out over time, and for outcome measures, you want to be certain that the impact on patients' health is also evidenced by positive and desired outcomes over a given period of time. Another point you may wish to consider is seasonal fluctuations, the when portion of data collection. For example, if you were considering your flu vaccination process, you would need to look at the same time period year over year. You would also want to consider unusual events that influence your data, for example, once a year. Maybe a national sporting event in your area during the summer where there have historically been a spike in ED admissions simply due to the number of out-of-town visitors for a period of time. Once you've determined what data you are going to collect, it's helpful to summarize the various aspects we've touched on by putting them together in a single document, a data collection plan. This doesn't have to be overly formal, and we'll look at a data collection plan tool on the next slide and cover the items listed out here. As you may conclude, these questions ask the who, where, when, and why, and what around collecting your data. One of the key questions you'll answer here is specifically the why of collecting data. Always keep the purpose of data collection in mind and determine why you need the data. Here's a data collection plan tool that you can use to keep your data collection efforts organized. The template offers some of the core or typical information that you would need to know about the measure that you are collecting. The information about the measure you are collecting is also known as metadata, facts and information about what you are collecting. Here are the fields in the data collection plan. Data to be collected, the specific data you intend to collect. Type of data, is it a date, number, certain number of decimal points, etc. Purpose of collection, why do you need to collect this specific field or set of data? Source, is the data coming from your EHR? Are you tallying up patient counts manually? And so on. Frequency, how often will you collect the data? And who is responsible for the data collection? You can convert this table to a Microsoft Excel format and then add additional columns as needed, such as stratification factors, which would describe a certain level of granularity that you need, such as by clinician, specific time factors, day, week, month, etc. The tool is meant to be flexible and is intended to be used hand in hand with a measure collection and monitoring plan. The measure collection and monitoring plan provides the high-level information about the measures, and the data collection plan helps you list out the details about your chosen measures. Thank you for taking time to learn about data basics and data collection as part of the Quality Improvement Basics course. Please join me for the next module in the course, Data Analysis and Data Display Methods.